Good evening. It's my pleasure to be hosting this webinar. Welcome to our session. We aim to be as interactive and enjoyable as possible. I will be very brief. My role is just really to give you a few housekeeping points. Please, if you do have any questions, please type them into the Q&A button at the bottom of the screen rather than the chat button. Our host for this session is Syed Aftab, and it's now my pleasure to hand over to Syed to take you through our wonderful evening. Thank you.
Hi, good afternoon. Thank you everybody for joining us this evening. My name is Syed Aftab. I'm a consultant in spinal surgery, and we are a group of spinal surgeons, and we work primarily on spines, but we have a collaboration with the London International Patient Services Organization where we really work collaboratively and referring to each other and use each other as support. Now, this evening's talk is about common spinal problems, community management, and how to essentially navigate the very difficult world that is spinal problems, including back pain management and any other issues that you might be keen to talk about. The main thing to say is that I'm not going to run today like a lecture. None of us here will be running today like a lecture, because that's not what we're mostly interested in. We're much more interested in having this as an interactive session. We obviously have a presentation ready for you, which we will be going through and reverting to, but it's much more useful for us if we actually have a discussion. And to that end, you're welcome to put things up on the chat at any point, which we'll be monitoring. And you're also encouraged to just unmute and start speaking when you have a question. What we don't want this to be is a lecture. I mean, all of us are professionals here, and we don't need to be, talking down to each other. We talk to each other as equals, and we treat each other as colleagues in this environment. So just ask us questions, call us out if we're not doing the right thing or if you think we're not going in the right way. I'm not going to do too much more talking. I'm going to be more of a facilitator. I'm a spinal surgeon. I'm going to hand over to Mr. Fadi Sedra at one point after the initial introductions. So without further ado, let me get on with this thing and get started. Okay, so good. So today's talk is also sponsored by Sentinel Spine. They're colleagues of ours in the implant industry who support us a lot with very helpful and interesting spinal implants. Just of note, Tiger Woods' spinal surgery was done with Sentinel Spine implants. It's they have quite a pretty good track record with their implants, and we work with them, but they're supporting this talk, so thank you very much to them. Fine, so we're not going to go crazy into detail today, but just a few things on objectives. We're going to talk about common spinal problems, and we're going to break it up into anatomy, assessment, and emergencies, just so we're safe. But again, like I said, I don't want this to be a lecture. Okay, so just a little bit of background on who we are. We're a group of spinal surgeons, pain doctors, neurosurgeons, spinal orthopedic surgeons, and our main focus is managing spinal issues, right? That's complex spine London. We're all people in central London teaching hospitals. The panel that you have here today is me, Syed Aftab, Barts Health, NHS Trust for Royal London, along with my colleague Fadi Sedra, who's also a consultant at the Royal London. Then we've got Dr. Basil Al-Mahdi, who's a consultant at the Whittington in pain management. We've got Dr. Norman Kufakura, who'll be joining us shortly, who's another consultant in pain management, also the medical director of Complex Spine London, and Mr. Ahmed Sadek, who'll be joining us from Queen's Hospital in Romford. He's just stuck in clinic with a couple of patients, but he'll be coming in as soon as possible. That's who we are, and there are loads of others, right? So we're about a 40-strong team managing any spine problem, cradle to grave, any pathology, intradural, extradural, whatever. So if you have any issues with a spine problem, just get in touch with us. We're quite approachable. I'll put up my email address at the end, so just feel free to call us, contact us, whatever you like, even if it's not to refer a patient, but you have a question. We're pretty good like that. We try to keep people engaged. So we actually meet weekly. We have an MDT where we go through cases properly. This isn't just like hey, let's meet up in the corridor and discuss a case MDT. This is a real MDT, right? So it's minuted. We have a terms of reference. It's formalized. It's indemnified. Everyone has a formal agreement. I mean, it's a proper MDT, and it's in fact the only MDT that runs this way in the private sector. It's in fact sometimes, you know, we take our lead from GIRF guidelines and things like that, but we're solid, and we have physiotherapists, we've got psychologists, we've got sports medicine guys, we've got, you know, all the whole range of people who manage spinal surgery and spinal back issues and back pain with respect to a multidisciplinary approach within our team. We literally cover anything backs, anything spines. We also look after the patient in a way that we believe is unique. So most complex cases are done as dual spinal surgery. We use routine spinal cord monitoring for any instrumented cases. We make sure that we run through a full pathway for patients before offering surgery. We're careful and we're good about this stuff, and we move patients through the process quickly, and we keep 19 out of 20 patients away from surgery and still keep them happy. We're also doing things at the forefront. So the first robotic spinal surgery was done by us, well done in our NHS practice at the Royal London Hospital. That's the Royal London Hospital rather than Complex Spine London, but you know, we're all at the Royal London primarily anyway. And we continue that. We also do some other minimally invasive stuff, which is slightly different in the way it's done compared to the traditional MIS stuff. Procedure called IMAS, developed in the United States with an over 10-year experience over there. We started doing it in the UK in 2017 with so far very good results. We do a lot of deformity and degenerative things in children and adults. We publish, try and keep things active. Fine. So, without furthermore into the background, I will ask my colleague, Mr. Fadi Sedra, to take it away from here. As I said, we're very keen on keeping this session really quite interactive. You know, we don't want to keep it, we don't want to make it something that's didactic or dogmatic or instructional. This is a discussion, and you know, feel free to ask questions. So, Mr. Sedra, when you're ready, take it away.
Thank you, Syed, for the introduction, and welcome everyone to this webinar. My name is Fadi Sedra. I am one of the pediatric and adult spinal surgeon at the Royal London Hospital in Bath Health, and I'm a part of the CSL MDT, and as Syed pointed out, we work collaboratively either in MDT, but also in practice. So I operate on so many occasions with Syed, and particularly on complex cases we do as two consultant operating. Last week, for example, I did a list with Dr. Norman Kofakuro. So we do a lot of work together, and we have established pathways between surgeons, pain management, physiotherapy, psychiatrists, rheumatologists, and so on and so forth. Obviously today, as Syed again pointed out, that we will be discussing the common problems around of the spinal pathologies, and we all know that particularly when it comes to topics such as back pain, it's quite costly to the NHS and also in private, and we need a strong governance framework in order to be absolutely sure that we are offering the right treatment to the right patient, particularly now that there are several modalities in terms of pain management, psychiatric support, and then finally surgery if deemed as the very last resort. Let's start off with some anatomy. We will not be going into details. However, we will be pointing out some salient points that, just as a refresher, in terms of the spine. I mean, we all know that it is formed of vertebrae in the cervical region, thoracic, lumbar, sacral, and finally at the bottom, the coccyx. Next slide, please. And there are a few ligaments that are of importance, particularly when we start reading MRI scans and CT scans We look for the anterior longitudinal ligament, which runs in front of the vertebral bodies, posterior longitudinal ligaments that run behind the posterior bodies, excuse me, behind the vertebral bodies. The flavum, which is basically yellow in color, and it acts as a protective ligament for the neural tissue, and we come across it particularly in cases of spinal canal stenosis, particularly in the elderly population, where the flavum gets hypertrophied and taking the place which is normally occupied by the nerves. And then finally, the interspinous and supraspinous ligaments, which are important particularly in traumatic situations. Also, we look at the spinal canal, transverse processes, and all the other bony elements which form the neural canal in which the nerves traverse. The spinal cord starts at the foramen magnum, and then it traverses all the way down. It gives a pair of nerves at each level, and then ends up in Cauda equina, which we will talk about later on. In terms of the assessment, obviously, every assessment starts with history taking in terms of the most distressing symptoms, past medical history, some social history, and examination, which is basically, as we've all learned, it's about assessing the motor function, sensation, and reflexes. There are few points to be particular, which are particular for spines, which are called the red flags. Next slide, please. Thank you. Excuse me. So, for example, the red flags is mainly the age of the patient, and if there is any thoracic pain, if there is any neurological deficit, bowel or bladder problems, saddle anesthesia. It's all about picking up the complex or dangerous pathologies, like the sinister pathologies like the tumors, infections, and acute nerve compression. Next slide, please. Sorry, Syed, the next. Can you? Yeah, perfect. And I now hand over to my colleague Syed. Back to you, Syed, again to talk to us about the Cauda equina syndrome as one of the emergencies.
All right, thanks, Fadi. Thanks for that little background in the anatomy of the spine and a couple of things on spinal assessment. So, like the title of this talk is Common Issues in the Spine and Management. So we don't really need to go too much about the Cauda equina compression syndrome. So if you don't mind, I'm just going to skip forward to the back pain side of things, and we'll come back to this later on just to make sure we're not missing anything. Okay, herniated nucleus pulposus, a slit disc. Now that's something that we commonly see. So let's talk about it. And again, if you have any questions from anybody, please, and panelists included, just unmute and start talking. Don't worry about it. So your herniated nucleus pulposus, commonly referred to or as the misnomer slit disc, is represented very nicely, is analogous to this jam donut. So it's dry on the outside, the disc, and it's wet on the inside with the nucleus pulposus. The dry annulus fibrosus on the outside gives the disc tensile strength, and the nucleus pulposus, which is gelatinous and liquid, gives you compressive strength. And together they confer a lot of stability on the spine and flexibility with the segmental movements that it can achieve in conjunction with the facets at the back of the spine. Now, the way I explain why we have problems with discs when we look at, scans of, let's say, when we scan 100 people off High Street, Kensington, 80% of 8-year-olds, 10% of 10-year-olds will have some kind of disc-degenerative changes. And that's the number that people quote when they talk about modic. But that's actually also true of discs and any kind of wear and tear related issues, desiccation, disc dehydration, disc bulge, all these things that we see on MRI scan reports. And, we start panicking, surgical referral recommended, and this and that. It's like, relax, calm down. It's okay. These things happen, right? That all represents the jam donut drying out over time. So the way I explain what a disc does in its various stages of wear and tear is that imagine you leave a jam donut outside for a while. At first, the annulus dries up, and then the nucleus pulposus dries up, and you get desiccation, right? First stage. Then after a time, the disc becomes craggy and is not so bouncy anymore. And if you press it, it becomes bulgy. That's a disc bulge. Then if you keep pressing it, at one point, the jam comes out of the donut. That's your herniated nucleus pulposus. Then at one point, that herniated nucleus pulposus can actually become disconnected from the main body of the jam. That's your sequestered disc. Now, the bit that's not analogous to the jam donut is that not every single jam donut comes with, or no jam donut comes with the spinal cord and branches on either side. The situation we have here is that in front, you've got a disc. If you look at this picture, right, you've got a disc. And then behind it, you've got the fecal sac. But in fact, what you have here is a structure in this area. Can you guys see my mouse, everybody? Fadi, could you just confirm that you can see my mouse pointer?
Not really.
Not really. Okay.
No side, no.
Don't worry about it. Okay, fine. So just behind the disc, in front of what's labeled the spinal canal, it indicates that the disc is in close proximity to the spinal canal. What it doesn't show is that there's a strong ligament there called the posterior longitudinal ligament, just in front of the structure labeled the spinal canal. That structure, in fact, stops the disc from coming out directly backwards whenever it dries out. So it actually likes to come out to the side that you see in the picture next to it labeled compressed nerve root. That's indeed the jam coming out of a hole in the outer coverings of the donut, subsequently causing a pressure on the nerve. Now that brings us on to the next thing. Is it a mechanical pressure on the nerve, or is it rather a like a new chemical thing? And the answer is that it probably is a bit of both, right? So this nucleus pulposus creates a lot of inflammation. It's immunogenic, it's highly reactive from an immune system point of view, and it creates what's called a high intensity zone that you can see in these acute discs, which are very painful. And that's the basis on which your injections work. If you give an injection to somebody with an acute disc prolapse, you actually settle down the inflammation and wash away those inflammatory mediators. Even if you were to just inject saline, you give the patient great benefit sometimes. Some people have done that. I've done that right at the beginning of the pandemic when I was afraid of using steroids, but somebody was desperate. So, you know, there are things that, you know, things not just obvious, but different ways of looking at the same thing. So it's not as if just because there's a slipped disc, you have to do an operation to remove that disc and, you know, remove the pressure on the nerve, otherwise the patient won't get better. The majority of patients do really well without doing anything like that. So what does the body do to this bit of jam that's come out? The body eventually takes away the inflammation, settles it down, right? And then within 6 weeks to 6 months, 90% of patients will have spontaneous resolution of symptoms, but they will have recurrence if they then don't strengthen the core and stabilize the spine. So how do you assess and examine these people in the community or anywhere indeed? You know, you want to check for neurology, the straight leg raise and Lessegs test or a sciatic stretch test. So you literally lift up the leg and you dorsiflex the ankle, right? And if it's positive, that's actually a pretty good way of telling that the sciatic nerve is irritated in some way or another. Okay. We use x-rays. That's prehistoric. We don't really use it much anymore, but an MRI is really the gold standard investigation for this. Yeah. So, you know, how do you manage it? In the first instance, you give them analgesia. You keep reassuring them and ask them to keep moving. You just don't say bed rest, which is what people used to do back in the day. That's actually a bad idea. That would weaken the muscles and cause bigger problems. Now, if there is severe pain and the patient can't wait and the analgesics don't work, you can do a nerve root injection or caudal epidural. That's the only indication that NICE approves for a caudal epidural in acute disc or acute impingement of a nerve or acute neurological pain. Do not do bed rest, and you do your swimming, Pilates, core, and yoga. Now, how is it that we actually manage this thing and make sure that it doesn't lead to anything dangerous? Well, if you have hard neurological signs, and essentially you're talking about a weakness in the foot or the leg or some description, or weakness of bowel and bladder. So a foot drop or Cauda equina compression. And there's more about Cauda equina compression that we'll come to in a few moments. Then you might need to do something surgically early. And even then, Cauda equina compression is really the only thing where you'll do surgically something immediately. With almost everything else, you can wait. Whilst a major radicular issue like a nerve problem is something that some people manage quickly, there are people who manage it within 6 weeks of onset of symptoms and they usually resolve. So there's gray area in all these things, but with Cauda equina, there isn't gray area. So that means that with a slip disc, almost everything apart from Cauda equina is managed non-emergent, in a non-emergent fashion, okay? So let's just have a quick chat about Cauda equina compression syndrome. So we're not going to go too much into heavy detail. And again, like I said before, at any point, feel free to just unmute and talk, put up questions and put up messages on the chat. You're looking, Cauda equina is primarily a clinical diagnosis, although people say that, oh, it's a clinical diagnosis, whatever. You still depend heavily on an MRI scan. And the MRI scan confirms your diagnosis. And it isn't just purely a clinical diagnosis. Yes, clinical assessment is important. And that's why people say it. But actually, if you have a wide open field goal for a spinal canal where the Cauda equina is, but you have Cauda equina symptoms, you know that this is not Cauda equina compression syndrome. So to say that this is just a clinical diagnosis, it's like it's old school surgical arrogance, you know, like if you don't put your foot in, you put your finger in, or some rubbish like that. You know, everything has, you know, you're allowed to use a brain. You're supposed to use a brain. So we have a low threshold for Cauda equina compression syndrome because there's a clock on it, which is a better way to describe it, okay? So your red flags are urinary retention. It's not just retention, it's actually overflow incontinence that the patient is getting. So you get retention, and then you don't usually know you're in retention, and then you get overflow incontinence. If you suspect it, you can do a bladder scan to see incomplete voiding, and the magic number is over 100 mils, but again, that's very subjective. Saddle pins and needles, loss of anal tone, motor weakness on both feet, and other things such as history of drug abuse, IVDUs usually, you get epidural collections and infections, history of cancer, unexplained weight loss, and fever, which is again another problem indicating infection. So if somebody comes to you and say, you know, for the last 24 hours, I can't use both my feet, hey, you know, I can't move my legs then, and it's really painful, okay, think about a Cauda equina. Or for the last, you know, since I woke up this morning, I'm peeing myself, okay, think about a Cauda equina. But if someone comes in and says, hey, I got a bit of a leg pain going on one leg, and my big toe doesn't feel as strong and coming up, it's probably not a Cauda equina. But if you're in doubt, have it checked out. Safest thing to do. Management, and oh yeah, and in the examination, you do want to do a PR exam. You do want to document everything very, very carefully. You want to look at tone, voluntary contraction, sensation, and any issues, just refer along. So that's your safety netting done. But the majority of patients who have your herniated nucleus pulposus, you're going to be giving them analgesia. I give them a combination. If they're really bad spasm, I give them some diazepam, 5 milligrams 3 times a day for about 3 to 5 days. Again, I then defer to my pain management colleagues. And then I give them some diclofenac. You know, I send off to a physiotherapy, and on occasion, I'll then get my pain management guys involved. Rarely I'll offer surgery. Okay, rarely, meaning 1 in 20 will have an operation once they've been through a process. Now, let's talk about that process. I'm not going to go too crazy into it. Basil, I'm going to spotlight you now so you can talk about this stuff. Would that be okay for you?
Yes, of course.
Okay, so switch on your video and go for it and just talk to us. I can actually switch off the slide and you can talk to us if you like, because okay. At this stage, what I would usually do is I would send the patient to my pain management colleague. I wouldn't jump in and do an injection myself generally, because we work in a true MDT. If I'm the surgeon and I've ruled out a surgical problem, I'm not going to offer him an operation. It's not fair for the patient to have me do the pain management because I'm not up to date with everything in pain management. I send it to a pain consultant. So Basil, I'm going to stop the screen share and then I want you to talk. If you want to use the slides again, just let me know. I'll start the share. Okay.
If you put me on video-wise, I'm disabled.
Oh, really? Hold on a moment. Ask to start video. Here we go.
Okay. Hello, everybody. The things that we do in terms of managing the pain in those situations and scenarios. Well, first, we've got plenty of medication that we can use, and we can titrate those medication in a way that helps the patient's symptoms and try and avoid the complications associated with most of the medication. None of the medication on its own is a robust, good choice for each and every case. We sometimes even rotate within the same medication in the same category. And we tend to try and avoid the use of strong opioids for long-term problem and long-term situation. But sometimes there is a place for opioid use in certain circumstances. There are every day there's a new kind of information to us about those old medications that we tend to use as a bread and butter, and we need to keep up with the advances in knowledge and not just to have a cliched medicinal prescription to each and every case. There are new medicinals innovations like the new upcoming cannabis-based medication that is coming steady and fast, and there's lots of information and studies happening to try and verify the importance and the benefits from these medications and the long-term safety. Apart from medications, interventions that we use similar interventions to the what Saeed mentioned, which is injecting substances around the nerve roots in those circumstances. Um, Steroids, injecting steroids to reduce the inflammation around the nerve root. Sometimes we use certain instruments or technologies called the pulse radio frequency interventions, and that works better for the chronic irritation of the nerve roots rather than the acute phase of disc prolapse and herniation. But if the disc prolapse and the herniation goes into a chronic phase, there will be a constant irritation of the root, and the dorsal root ganglion will be inflamed and turns on the chronic phase of stimulation. And in those circumstances, going there with a needle and using electrical modalities to try and stimulate that dorsal root ganglion in a way that switches off the over stimulation, like plugging stuff from off electricity and then try to put it on again. And that is the interventional side of what we do. We can do epidurals and total epidurals as well, but the main intervention is steroid injection, transforaminal epidural in disc prolapse. And as Said said, it works well for the acute phase, and that's why it is even acknowledged by NICE guidance as a route of intervention in the acute phase first 3 months. The other problem I just want to discuss is the facet joint pain, the mechanical facet joint pain, which is, if say it shows me the slide that shows the facet joints, and I just want to explain about it a bit. So those facet joints basically are like hinges. They are joints, synovial joints, like the knee joints, the shoulder joints, joints all over the body, and they have a synovial membrane attached to it. And because of that, they are prone to arthritis. And we all get a degree of arthritis in those facet joints with age, but it's like gray hair. Some people get it quite early, but it doesn't bother them. And some people get a one simple gray hair up their head and they're quite frustrated by it. In a similar analogy, the facet joint changes sometimes are minimum, but they cause significant pain and distress to patients. And sometimes you x-ray someone or scan someone for another reason, you see a very much complex, advanced osteoarthritic changes in those joints, but the patient is not bothered by it and it's not in pain. So facet joint pain is a diagnosis that is mainly clinical, but is, as the other spinal pathology, supported by radiological evidence. Now, their pain is characteristic by being osteoarthritic pain, which is worse first thing in the morning, worse when they immobilize for a while, worse when they bend backward. That's why they stoop forward as if they are pushing a pram, and that opens the space in the facet joints and makes it make less pressure intra-articularly, and that makes the pain a little bit better. Now, what do we do about it? Of course, apart from the common themes that we talked about, where we employ physiotherapy, simple advice for them to mobilize and be sporty and do as much as they can in a safe manner, we can do interventions. And the interventions that we used to do in the past was just merely a facet joint injection with steroids. Now, we found that this has got a role, but it's limited because the inflammation will flare up again after a few months. So the change was to try and target the nerve that senses the pain from those facet joints. And this is what we call medial branch block. And the medial branch block can be followed up by a medial branch denervation, where we can go with the needles, a needle type intervention, and burn that small sensory nerve that senses the pain from the facet joints with what we call radio frequency treatment. And again, it's a non-invasive way to switch off the pain sensation from those arthritic facet joints and improve the pain experience to the patient. It should go hands in hands with other interventions like the physiotherapy, hypnosis, stretching, exercises. All are aimed to improve the functionality of the patient around the long-standing clinical problem, which is the facet arthropathy or arthritis of those facet joints. Now, it's not something that we can cure, but in certain circumstances where there is a very severe disabling pain problem, and if it is associated with other um, uh, abnormalities that causes, for example, the spines to move onto each other with pars defect, or cause an increase in size of the facet joint that pushes onto the nerves inside the canal and can participate to canal stenosis. In those circumstances, surgical intervention will be advised, and that's why we keep kind of a fluid communication between the spinal surgical team and us pain consultants to try and deliver the most suitable treatment for the patient at that moment of time. I think I covered the pain intervention for disc prolapse and the facet joint related pain problems. And I think I'll pass the ball back to Sayed to talk about more surgical issues.
Thank you very much, Basil. That's really handy information to have. Like, that's exactly what, it's exactly the kind of thing that I want to know about. And that's the reason why I don't manage these acute discs on my own, because your understanding of it is far greater than mine. Thank you very much, Ahmed and Dr. Kufa-Kwaro, Mr. Ahmed Sadek and Norman Kufa-Kwaro, who are my consultants. Ahmed is a consultant spinal neurosurgeon, and Dr. Kufa-Kwaro, he is another pain consultant. So I'm going to go away now from this session that we've been doing with lectures and slides and things like that. And I just want to have a discussion with us. So guys, let me ask you guys a question. Let's say that we've got a back issue, right? So in community, and I'm sitting in a community clinic somewhere. The most common problems that I'm going to see are doing my back in, so having back spasms or low mechanical back pain where you don't have a back issue from a radiological perspective, or if you do have a radiological abnormality, it is probably not related to your pain perception. Or the second commonest thing is that you have a slipped disc, which actually sits around in many people and not necessarily are all symptomatic, but they cause a problem. So, I mean, Basil, you've told us a little bit about what you do. Norman, why don't you just open with a little bit about how you manage these things? I mean, what would you suggest? And in particular, I want to have a discussion about what role other novel treatments might have. So, for example, I say that because, Norman, I know that you've got an interest in CBD, and I know, Basil, that you have an interest in THC, and these are novel things that we're using currently. Where do you see this fitting into the picture, and how might this help some of our community colleagues in primary care and physiotherapy in managing their patients? Norman?
Thank you very much, Saeed, for that. I think Basil has covered, most of the things that we do on a daily basis in terms of managing, pain related to the discs and the facets. I'm sure we've all heard about, people talking about, CBD or cannabinoid oil. I'll let, Basil, talk about THC because he's got a special interest in that. CBD oil is classified as a food beverage, and it works on, some of the cannabinoid receptors. As we know, the body is full of cannabinoid receptors, and we've seen a lot of patients that have tried various treatments, including injections and some conventional and non-conventional to respond, the change. The evidence, especially for back pain, not a lot at the moment. Just like anything to do with medical cannabis, most of the studies are very small, small powered, studies with very few patients involved. But we've seen, evidence emerging that is very helpful for conditions like fibromyalgia and some neuropathic pain conditions, particularly that are related to multiple sclerosis. I know as we speak that there's quite a lot of research going on at the moment looking at back pain, particularly non-specific back pain, where the discs and facets all look normal. So most of these patients take cannabinoid oil, which seems to help them quite a lot. Ideally, sorry, Said. And what I meant is, 30 to 50 milligrams 3 to 4 times a day, which can be up-titrated slowly. And then once you've optimized cannabinoid oil, if they're not responding, and then, you could try THC, which is tetrahydrocannabinoid. That is not available on the NHS at the moment, but we know that there are a few private clinics that offer this, that can, prescribe medical cannabis. I think my colleague Basil works closely with one of the groups that is quite prominent in London and has been prescribing to a lot of patients. Basil, I'll be grateful if you could take it from here.
Yeah.
So the cannabinoid system is a very recently the most recent system in the body that's been discovered. People used cannabis for centuries, and it goes back to the Chinese medicine and the old Indian texts. But people, even in the modern medicine, try to use it and before it gets criminalized and Red Cross brought to it. But we didn't understand how it works and why it helps. And in the 90s, the system was discovered. The receptors were cultivated, and now we know that this system is very widespread all over the body. And we've got 2 types of receptors, CB1 and CB2, and they are present presynaptically in each and every cell, most predominantly in the nervous system for CB1, and most predominantly in the immune system for the CB2. And now we are advancing our knowledge in the fascinating role of the immune system in pain management and in pain progression, and in the microglial cells around the neurons, where we thought is just a supportive cell and has not much of a role in treating transmitting pain. Now we're finding that those microglial cells have got a significant role in the modulation of pain, and that's where those new medicinal frontiers have been opened. And one of those is the cannabis-based medication. And as Norman said, the CBD is one of 2 main cannabinoids that are around there, and the THC is the other one. THC has got a little bit more psychoactive effect, and that's why it's a second line to the CBD oil, and only the CBD oil fails to achieve success. We tend to consider THC as an alternative or as an additional to the CBD oil. Now there are endocannabinoids. The system has got, our body has got endocannabinoids, cannabinoids of its own make, and that's what makes this cannabinoid business more natural, more close to what the body's own ability to produce, and it's a natural substance that the body itself got and possess, and that's why it's a little bit more reassuring for us. However, there are lots of studies happening to verify, as I mentioned earlier, the role of those new medication in the new frontiers, and the future is hopefully bright in that perspective.
The future's bright, the future's orange, if you remember that from the 90s, eh? Thanks, Basil, and thanks, Norman, for that. So, I mean, in summary, just to summarize what you said about CBD and THC, these are new things. There are social stigma associated with it. There is a role for it in medicine. It's a poorly understood system because it's the newest receptor system that we're aware of. This is something that we can use to our advantage, and it works in, CBD is a food supplement, so anyone can actually buy it themselves, and it has its applications, something to be aware of. I think let's move on from that side of the thing for the moment. We've talked a lot about herniated nucleus pulposus, low mechanical back pain, facet arthropathy, and CBD. Ahmed Sadek, thanks for joining us, my friend. Glad to have you on board. I just want to ask you a couple of questions. You're a spinal neurosurgeon, right? We work together. I look at a spine from bottom up. You look at a spine from top down. And I also look at a spine from outside in, and you look at a spine from inside out. So tell me, I mean, another question that a lot of the people who will watch this video will have is, when should they send to a neurosurgeon? And when should they send to an orthopedic surgeon? How do you answer that question?
Well, I think first of all, it's really critically important to understand that the notion of a neurosurgeon and an orthopedic surgeon are different. They're not really different. We have a common stem, and that's spinal surgery. And that is a subspecialty in its own right. And that subspecialty is made up of orthopedic spinal surgeons and spinal neurosurgeons. So that's the first thing. As a cohort of surgeons, we exist harmoniously together and have our own subspecialist interests. So Syed, you're absolutely right. I view it from in out, from the neural elements and then out through the neural foramen and the bony structures. And because of your training, you view it from the osseous anatomy in. But our common stem is preservation of neural function, and that's where we really meet. And the beauty of our group, Complex Spine London, is that we're made up of a combination of both orthopedically trained spinal surgeons, and I think that's probably the best way to term our profession, and neurosurgery trained spine surgeons. So I have a particular interest in the cervical spine and everything within the dura, i.e. the benign peripheral nerve tumors and the more malignant tumors that occupy the intradural space and the peripheral nerves in and around the spinal column. And that's because I'm a neurosurgeon and I'm accustomed to working within that compartment, and that's because of the common stem of neurosurgical training. But I've been very fortunate in that I've been able to spend a significant period of my training with my orthopedic colleagues, both Mr. Aftab and Mr. Sidra, where I, became a more full neurosurgeon. And similarly, Mr. Aftab and Mr. Sidra have spent time with neurosurgeons and gained an appreciation for those intricacies associated with the neural preservation. There are obviously differences between us. Mr. Aftab and Mr. Sidra are exemplary deformity surgeons, whereas I don't really perform complex deformity surgery. My primary interest or subspecialist interest is the intradural pathology, the tumors associated with the spinal cord. I don't think you should necessarily pick out an orthopedic surgeon or a neurosurgeon when you go to refer a spinal patient. A spinal patient can be appraised by a spinal surgeon, and spinal surgeons come in two varieties: those that have been trained as a common stem orthopod or a common stem neurosurgeon. That appraisal can be performed by any spinal surgeon. As a group, we all have our interests, and as GPs and allied health professionals, we all have our subspecialty interests. So certainly the spinal patient can be appraised by any spinal patient can be appraised by any spinal practitioner or surgeon, but the final management of the subspecialties, i.e. the deformity or the tumors or the complex craniocervical work, may have to go to a subspecialist. So certainly I don't like the notion of viewing us as separate entities. We're actually a subspecialty within our own right, and within our own departments, we're viewed as a completely different profession in a sense. And I think all my surgical colleagues would share those sentiments.
Yeah, perfect. Ahmed, I love that answer. And I like asking you this question and stuff like that, because if you remember when we did the talk for the medical students, we had a similar discussion and we said the same kind of things. And we always circle back to the fact that we're all surgeons of the spine. You're neurosurgically trained, I'm orthopedically trained, but ultimately we're working on the same thing. But there's a 95% overlap in what we do. You said that I'm great at deformity. Yeah, we do deformity, but I don't think I'm great at it. I'm good at it, I'm okay. You are actually very good at intradural stuff where I have no idea, I'm totally out of my comfort zone. But by working together, we make sure that there's nothing in the spine that we can't sort out between us. So if I have a patient and I have a tumor that comes in from, you know, like a meningioma or something, I say, Ahmed, I need to sort it out, please help me. And he'll take it over and deal with it, and we'll discuss it in MDT and it'll be done. Okay, fine. So let's stick with this theme, Ahmed, for the moment, if you don't mind. Let me just ask you another question. So often, you know, like you hear horror stories. So a patient turns up to a GP with a headache, and they're like, yeah, see you later, go away, don't worry, you're fine. Go away, don't worry. And next thing you know, they passed out, they've got a big, massive brain tumor, and they're like gonna die tomorrow. It's like, whoa, what the hell? We've all heard those stories. How do you mitigate for that? I mean, how do you know when something is nasty? And, you know, are you going to send everything for a neurosurgery review or spinally trained orthopedic surgeon review or a fish scan? Or, you know, what are you looking at when you're thinking about these patients?
So, excellent question, and a really important question. And there are certain salient points that everyone who deals with the spinal patient per se should be aware of. And to be honest, those points are quite simple, and we can break them down into two things, pain and function. And any patient that has unremitting pain, and this is not conjecture, this is solid evidence that stems from the NICE guidelines. And we have really quite robust evidence that stems from protocols that NICE have issued, and they all allude to how to manage these patients. We have what we call red flags, those flags that light a bulb in your head and make you think, look, that patient needs to see a specialist as a matter of urgency. And we touched briefly upon that right at the start of this lecture on Cauda Equina syndrome, and you'll be aware of other type syndromes or constellation of symptoms and signs such as myeloid radiculopathy, which is a stenosis affecting the function of the cervical and thoracic spine, where you have a loss of function and a severe unremitting pain. So any patient that you have that you've been unable to manage their pain using your standard analgesic ladder, and that pain follows a specific dermatome and may or may not be associated with a functional loss. That functional loss can manifest as a weakness, a myotomal dysfunction, or a fine motor loss, which is a combination of proprioceptive loss, light touch, etc., etc. Those patients you need to be alerted to, and they should be referred to a subspecialist. Now, when we go to the rarer conditions that Mr. Aftab hinted to, the tumors. So the tumors are, although they're incredibly complex, their presentation is synonymous, it's categorical, it's always the same. Our spinal cord tumor patients will present with nocturnal pain. No one should have nighttime pain. When you're asleep, you're hypotonic, your neural firing is significantly reduced. You have your alpha beta waves, your brain goes to sleep, your whole body falls asleep, and the hardwiring system that allows you to turn the 70 odd times a night is completely subconscious. When you have a tumor within the canal space, it occupies a volume, and that volume displaces normal neuronal activity and normal neurons. And the pertinent sign here is pain. So anyone that walks into your clinic complaining of nighttime pain or pain that wakes them up from sleep has something nasty going on and needs to be investigated thoroughly. And I think if there's one take-home message from our talk regarding tumors of the spine, it's that. It really is that. Nighttime pain is the first salient point that you will encounter. After that, you will encounter what? Functional loss, weakness, inability to ascend or descend stairs, inability to type or do up buttons. And ironically, those are exactly the same signs and symptoms that you will see with the degenerative processes or the malignant processes as a result of metastases from elsewhere in the body. The spine is wonderful. It's an incredibly small structure, and alterations in its function always manifest as sensory disturbance, motor disturbance, and functional loss. So I think in summary, functional loss and pain are red flags. Those are the signs that really should highlight that a patient should go to a specialist, a spinal surgeon.
I love that. That's really, really concise and really good. And actually, that is actually, you know, I treat patients all the time, and I wish I could have said it like that myself. That's really good, Ahmed. Thank you very much for that. Much appreciated. Fine. Okay, so that brings me on to the next question. A lot of the times we're going to be in the community or wherever, and I know this because like a parent from my kid's school will call me up and say, Saeed, my 14-year-old older child has back pain. What do I do? So I know that children with pain is actually surprisingly common, and it happens. So Fadi, as a spinal surgeon with a specialist interest in pediatrics, what are your thoughts on back pain in kids?
Thanks, Syed. I mean, it's a problem that we now see more often that we used to see before, and it's probably because more and more children are now into sports and activities, and now we see so many kids who are involved in more than one sport and in more than one activity. And I remember one time a patient who literally came to see me with lower back pain, and who literally had an activity on every day. So obviously, as we mentioned in the beginning of this talk about the red flags, and the kids by inherently their age will be a red flag in terms of pain, and that from the outset, I will have a very low threshold to take this symptom seriously and proceed with an MRI scan of the lumbar spine. So I would just from the outset just to point it out. But whenever I see a child with low back pain, I'm thinking there are a few points that needs to be pointed out in the history, and from that, is it mechanical or non-mechanical? As Ahmed rightly said, I mean, if it is non-mechanical pain or night pain, then we should put this patient on the fast track in terms of scanning, because we might be dealing with a tumor situation. If it is mechanical back pain, then we're probably going down the route of maybe spondylolysis or a spondylolisthesis rather also. However, we cannot rule out infection in those situations. So there are a few points to be covered in history, as in a recent travel to abroad, or if there is any associated constitutional symptoms or history, either personal history or family history of tuberculosis and so on and so forth. It's quite important to cover this in the history. In any way, I mean, if we're dealing with a scenario where there is a predominantly mechanical lower back pain, then I usually request an MRI scan and then see the patient again with the MRI scan and see if we are dealing with a situation where there is spondylolysis, which is not uncommon, particularly, as I said, in this day and age where children are more into activity, sports, and so on and so forth, at which point I'll usually pull the child out of the sport or activity for a few weeks, and that should deal with this situation. In that, more often than not, we see bone marrow edema in the pars interarticularis, which is the part of the spine connecting the two consecutive vertebral segments, and that usually in that situation the pain subsides. If we are dealing with a situation of a spondylolysis where the pars has already broken, or a listhesis in that the pars has broke, or and there is a slip in the vertebra, then again we treat that conservatively, and in a very resistant situations we can offer surgery.
Thank you. Oh, sorry. Carry on.
We see very few cases of herniated lumbar disc in children in the pediatric age group, and I can't remember the last time I had to do an injection for a pediatric patient. Almost always conservative treatment will help with the symptoms.
Thanks, Fadi. Another question that people ask all the time: does scoliosis cause back pain?
Again, a very interesting question. Yes, it does, only because the mechanics is of weight transmission is distorted, in which in that there is a overload on the facet joints, and in some situations the constant ache or back pain is one of the indications, or one of the things that actually pushes the patient towards surgery, just to get rid of back pain. There is also the deformity, the sagittal plane deformity, or Schweiermann's kyphosis, in which the patient has a rounded shoulder, and they also come with back pain, and it's one of the indications where we could offer spinal fusion for. Nevertheless, if it is the painful scoliosis, again has to be dealt with very carefully, because sometimes the scoliosis might be driven by a herniated disc, or in very few situations we might be dealing with a tumor like osteoid osteoma or even osteoblastoma. And this is quite clear in the history, in that the pain is not mechanical, and again, we do not operate on any scoliosis unless we get an MRI scan, and this should pick it up.
Thanks for that, Fadi. That's really handy. So just to summarize, we've done a whistle-stop tour through a bit of the anatomy of spinal surgery. We went through the red flags, we went through low mechanical back pain, facet arthropathy, avant-garde things that we can use to manage these things, such as CBD and THC. We talked about spinal tumors, and we've come back to talking about deformities and pediatric issues in children, with respect to the spine, that is. We've got 3 minutes left. And Norman, I'm going to invite you at this stage to just quickly give us a little rundown of what working multidisciplinary means. I'm not just talking about surgeon and pain doctors. What are the other things? Like, I'm talking about your psychology, your physiotherapy, chiropractic. How does that fit into this whole picture?
Oh, thank you very much, Saeed. As Complex Spine London, we work as in a multidisciplinary fashion, in the sense that we have spinal surgeons, we have neurosurgeons in the group, we have pain physicians, we have physiotherapists, we have chiropractors, and psychologists as well. As we know, pain has multiple modes. Besides the physical pain that people complain of, there are also emotions associated with that, which can lead to mood disorders. And in addition to that, due to reduced mobility, you can get deconditioning of the muscles. So it's very critical that when you see a patient with back pain, that you offer them multimodal management, which includes all the basic analgesics that we can offer them, and injectables as well. And in addition to that, physiotherapy, and more importantly, psychology. I think psychology is one aspect that is overlooked by a lot of people. We tend to overlook the fact that when pain is transmitted to the brain, it does pass through two very important centers which control your mood or your happiness and also sleep. So most of the patients that we end up looking after have got issues with sleeping at night. That's the most complaint that I get, that doctor, I can't sleep at night. And in addition to that, my mood is very low, I'm getting depressed, or if they're suffering from depression, my depression is getting worse. So it's really critical that when we're looking after these patients, we're not only looking at offering them analgesics, injections or surgery, but we have to take into account that there are other aspects of the chronic pain that have to be managed very well. So as Complex Spine London, we offer all these services. In essence, I think if a patient, I think Saeed would agree with me, and Basil and all that, that we consider surgery as last resort. When most patients come and see us, they're offered physiotherapy to start with, and they get seen by a surgeon to exclude any red flags or surgical targets. and then they get referred to pain management, where we go through the conventional, non-conventional analgesics, offer them injectables if possible, and then assess their mood as well, so that we can refer them accordingly to, to a psychologist if required, where they offered, things like cognitive behavior therapy, acceptance and commitment therapy. So when a patient is referred to complex spine, they essentially get the full package available in front of them, rather than just being offered injections, which I think is very critical in managing pain. This system seems to work very well on the NHS, but on the private sector, it's not very well developed. I think complex spine, I'm sure my colleagues agree with me, is one of the few private multidisciplinary consortium that offers this service very well.
Thank you very much, Norman. Okay, we're now at time. Basil, last question for you. If somebody is having a patient in the community who has back pain, what would be the one thing you'd ask them to do to help the patient?
I would ask them to mobilize the patient, ask the patient to be as active as possible, and to avoid hooking them on long-term opioids, strong opioids, because that is really a very significant problem that we face from patients being treated or being kept in the community for long. So if there's one problem I would love to avoid, is to see patients late who are on a high dose of strong opioids, and then we'll be managing two problems rather than...
Thank you. We've had a great question. From Dirk Reynolds, what natural solutions are considered with pain and neural issues are concerned? Example, essential oils, copaiba and frankincense. What are your views on that?
I have had lots of study on the non-medicinal input and non-medicinal substances in management of pain. And as far as stands now, the most successful, sustainable in clinical trials is the CBD. I've worked in the for a period of my career in the London homeopathic hospital or London Hospital for Homeopathic Medicine, and I went through in my research post what they offer, and there wasn't anything that had substantive clinical evidence that would support us advising for its use. The CBD oil, as far as stands, the one and only thing that passed that test, and it is a natural remedy that is working on receptors in the body with an endogenous substance that it mimics, and that's the one and only thing that I feel confident to advise.
Great. Well, okay, so we've got a question. Have any trials been conducted on essential oils, as far as you know?
As far as I know, not many. I'm aware of things that when I was at the London Homeopathic Hospital, and there were not of great success. There were a few of case studies which are weak evidence. Case studies are not strong evidence to promote medicinal or intervention. So there was no robust randomized trial, clinical trial, or prospective trial that supports the use of those essential oils.
Great. Well, thank you very much, Basil. Thank you, everybody, for joining this session. I think it was a great discussion on how to manage common problems in the community, and we really went into quite some detail about some things. I think that brings this session to an end. There will be a recording available for this. Thank you very much for joining. If there are any questions at all, my email address, you can just email us. You can email me directly, in fact, and it's syed@complexspine.london. I'm putting it in the chat. In fact, all our email addresses are first name @complexspine.london. So if you want to call Basil, it's BASIL at complexspine.london. Norman is Norman at complexspine.london. Fadi, FADY at complexspine.london. And Ahmed is AHMED at complexspine.london. So look, thanks a lot for your time. It's an evening on a Monday. I'm sure we all have things to do. I'm going to bring the session to a close. Any issues, get in touch. Thank you very much. Take care now. Bye-bye.
Bye.